Welcome to NCLEX-ReviewPro. Today we're diving into one of the most high-yield areas of your exam: IV therapy, electrolytes, acid-base balance, blood transfusions, and lab values. Why these topics? Because fluids, electrolytes, and blood products sit at the very center of nursing safety. One mistake here can be life-threatening. That's why the NCLEX exam focuses so heavily on them. It wants to know if you can recognize danger signs and act fast. Here's how this lecture will work. You'll practice a variety of next-generation NCLEX question types: multiple choice, select all that apply, ordered response, bow tie, highlight, drop-down, and matrix. If they feel tricky at first, don't worry. We'll break each one down step by step. And here's the most important part. For every question, we'll review not only the correct answer, but also the rationale. You'll see why the right option is right, and just as important, why the wrong ones are wrong. This is how you build the clinical judgment you need to pass the NCLEX exam with confidence. Think of this as your safe practice zone. If you miss a question here, that's not failure, it's learning. By the end, you'll know the must-have content and you'll feel ready to handle every NGN format the exam can throw at you. All right, let's get started with our first section: IV therapy and electrolytes. A client with a central line suddenly develops shortness of breath and chest pain. The nurse suspects an air embolism. What is the first action the nurse should take? Option A, administer oxygen at 2 liters per minute. Option B, place the client on the left side in Trendelenburg position. Option C, notify the healthcare provider immediately. Option D, flush the central line with normal saline. Pause here and think about which step comes first. The correct answer is B. Place the client on the left side in Trendelenburg position. This position traps air in the right atrium and prevents it from moving into the pulmonary circulation. Oxygen may be given later, and the provider should be notified, but the immediate life-saving action is positioning. Flushing the line is dangerous. It could push more air into circulation. NCLEX alert. The first nursing action in suspected air embolism is always positioning. Left side, Trendelenburg. Good work. That's a classic IV therapy safety question. Now let's raise the challenge with a select all that apply question on central line care. The nurse is preparing to change the dressing on a client's central venous catheter. Which actions are correct? Select all that apply. Option 1. Use sterile technique. Option 2. Have the client turn their head away. Option 3. Flush the line before changing the dressing. Option 4. Apply a mask to both nurse and client. Option 5. Reuse the old securement device if it's intact. Take a moment and select all that apply. The correct answers are Option 2, Option 3, and Option 4. Use a sterile technique when applying the new dressing. Turn the client's head away to reduce contamination. Apply masks to both the nurse and the client. Using only clean gloves to remove the old dressing is not sufficient for the full change. Flushing before the change isn't required. NCLEX alert. Central line dressing changes follow full sterile protocol to prevent catheter-related infection. Good. Now let's move to infiltration management with an ordered response sequence. A nurse is caring for a client with an infiltrated IV site. Which actions should the nurse take? And in what order? Option 1. Remove the IV catheter. Option 2. Elevate the extremity. Option 3. Apply a warm compress. Option 4. Restart the IV in a different site. Take a moment and think about the correct sequence. The correct order is Option 1. Remove the IV catheter. Next, Option 2. Elevate the extremity. Then, Option 3. Apply a warm compress. Finally, Option 4. Restart the IV at a different site. Removing the catheter first prevents further fluid leakage. Elevation decreases swelling. Warm compresses improve circulation and absorption. Only after those steps is it safe to restart the IV. NCLEX alert. For infiltrations, always remove the IV first. Never try to flush the site. Great job! Ordered response questions check whether you know not only what to do, but the correct sequence to keep the client safe. Now let's look at a matrix question on distinguishing infiltration from phlebitis. A nurse is assessing two different IV sites. Match each finding with the condition, infiltration or phlebitis. Findings: cool skin, swelling, and leakage at the site. Redness, warmth, and a palpable cord along the vein. Take a moment and decide which belongs to infiltration and which belongs to phlebitis. Cool skin, swelling, and leakage at the site indicate infiltration. Redness, warmth, and a palpable cord along the vein indicate phlebitis. Infiltration occurs when IV fluid leaks into surrounding tissue. That's why the site is cool and swollen. Phlebitis is inflammation of the vein, which shows up as redness, warmth, and tenderness along the vessel. NCLEX alert. Always stop the infusion immediately if you suspect infiltration or phlebitis. Continuing can cause tissue or vein damage. Great work! Matrix questions are all about comparing conditions side by side. Now let's shift from local IV site problems to a systemic issue, fluid volume excess. Here's the scenario. A client with chronic kidney disease presents with dyspnea and crackles. Review the following findings and indicate whether they are expected in fluid volume excess or not expected. Bounding pulses, flat neck veins, increased blood pressure, decreased central venous pressure, pulmonary crackles. Pause and make your matches. Bounding pulses, expected in fluid volume excess. Flat neck veins, not expected. Increased blood pressure, expected. Decreased central venous pressure, not expected. Pulmonary crackles, expected. Rationale: fluid volume excess increases vascular volume, which leads to bounding pulses, higher blood pressure, higher CVP, and pulmonary congestion. Flat neck veins and low CVP are signs of fluid deficit, not overload. NCLEX alert. Fluid overload often comes with dilutional hyponatremia. Always monitor serum sodium closely. Matrix questions really test your ability to compare. To make sure we're solid, let's take on a few more traditional NCLEX-style formats: a multiple choice, a SATA, and an ordered response, before we challenge ourselves with highlight, drop down, and bow tie. A client with pancreatitis has a calcium level of 7.8 milligrams per deciliter. Which sign would the nurse expect? Option A, positive Trousseau's sign. Option B, shortened QT interval. Option C, hypoactive bowel sounds. Option D, decreased neuromuscular excitability. Pause here and think it through. The correct answer is option A, positive Trousseau sign. Rationale: hypocalcemia increases neuromuscular excitability. This leads to tetany, seizures, and classic signs like Trousseau's and Chvostek's. A shortened QT interval, hypoactive bowel sounds, and decreased neuromuscular excitability are all associated with hypercalcemia, not hypocalcemia. NCLEX alert. Clients with symptomatic hypocalcemia need seizure precautions. Keep emergency calcium gluconate available. Now, let's look at how severe electrolyte imbalances show up on the ECG, specifically hypokalemia. A client's potassium level is 2.5 milliequivalents per liter. Which ECG findings should the nurse expect? Select all that apply. The correct answers are U waves, inverted T waves, and depressed ST segment. Severe hypokalemia delays ventricular repolarization. This produces U waves, inverted or flattened T waves, and ST depression. Absent P waves are seen in atrial fibrillation, not hypokalemia. A widened QRS complex is more typical of hyperkalemia or hypermagnesemia. NCLEX-alert always confirm potassium levels before acting on ECG changes. A hemolyzed sample can give false highs or lows. Now let's review the priority actions for a client with severe hypophosphatemia. A client with malnutrition has a serum phosphate level of 1.5 milligrams per deciliter. Place in order the nurse's priority actions. Notify the healthcare provider for a replacement order. Administer the prescribed phosphate supplement. Monitor for muscle weakness and respiratory effort. Educate the client on high phosphate foods. Pause and decide on the correct sequence. The correct order is: first, notify the healthcare provider for a replacement order. Second, monitor for muscle weakness and respiratory effort. Third, administer the prescribed phosphate supplement. And finally, educate on high phosphate foods. Rationale: hypophosphatemia can cause muscle weakness and impaired respiratory drive. The immediate step is notifying the provider, then ensuring safety by monitoring weakness and breathing. Replacement is given next, followed by long-term teaching on diet. NCLEX-alert. Never give phosphate IV push. It must be diluted and infused. Rapid administration can trigger severe hypocalcemia. Now that we practiced the core formats like multiple choice, SATA, order response, and matrix, let's step into the advanced next-generation question types, starting with highlight the text. This one is about total parenteral nutrition, or TPN. TPN is a method of giving complete nutrition, including glucose, amino acids, fats, vitamins, and electrolytes, directly into the bloodstream through a central line, when the client's GI tract can't be used. It's life-saving, but it also carries major risks, especially infection and hyperglycemia. Let's see if you can pick out the signs of those complications. Question: a client receiving total parenteral nutrition develops new findings. Highlight the two that suggest a complication. On assessment, the nurse notes hyperglycemia, clear lung sounds, a soft abdomen, fever and chills, and stable electrolytes. Pause and highlight the findings that point to a complication. The correct highlights are hyperglycemia and fever with chills. Rationale: TPN can cause hyperglycemia due to the high dextrose concentration. Fever and chills suggest a line infection. Clear lung sounds, a soft abdomen, and stable electrolytes are expected findings, not complications. NCLEX-alert. Clients on TPN need frequent glucose checks and strict aseptic line care to prevent infection. Now let's see what happens when potassium is too high. A client has a serum potassium level of 6.1 milliequivalents per liter. Highlight the two ECG findings that would be expected. On telemetry, the nurse observes flat P waves, tall peaked T waves, widened QRS complexes, and depressed ST segments. Pause and highlight the expected findings. The correct highlights are tall peaked T waves and widened QRS complexes. Hyperkalemia causes faster ventricular repolarization and slows conduction. That's why the T wave becomes tall and peaked, and the QRS complex widens. A depressed ST segment is linked to hypokalemia, not hyperkalemia. Flat P waves can happen, but they're not the hallmark signs. NCLEX-alert. Hyperkalemia can cause fatal arrhythmias, including asystole. Continuous cardiac monitoring is mandatory. Let's pause for a quick reminder. The normal potassium range is 3.5 to 5 milliequivalents per liter. Even a small rise above 5 can trigger ECG changes. At 6 and above, you should be on high alert for arrhythmias. The priority interventions are to place the client on a monitor, notify the provider, and be ready to administer calcium gluconate, insulin with glucose, or other potassium-lowering treatments as prescribed. Never ignore peak T waves. They're often the first warning sign before the rhythm collapses. Now let's move on to a drop-down question. A provider prescribes potassium chloride 20 milliequivalents in 100 milliliters of normal saline to be infused over 1 hour. Which statements are correct? Select the correct drop-down option for each blank. Potassium chloride must always be administered. Drop-down options: IV push, diluted in IV fluid, or given orally only. The nurse should program the infusion pump for a flow rate of drop-down options: 25 milliliters per hour, 50 milliliters per hour, or 100 milliliters per hour. The maximum safe infusion rate for a peripheral administration is drop-down options: 10 milliequivalents per hour, 20 milliequivalents per hour, or 40 milliequivalents per hour. Pause and select your answers. The correct answers are diluted in IV fluid, 100 milliliters per hour, 10 milliequivalents per hour. Rationale: potassium must always be diluted in IV fluid, never given as IV push. In this prescription, 100 milliliters must infuse over 1 hour, which equals a flow rate of 100 milliliters per hour. For peripheral lines, the safe maximum infusion rate is 10 milliequivalents per hour. Central lines may allow up to 20 milliequivalents per hour if the client is on continuous cardiac monitoring. NCLEX alert: always use an infusion pump for potassium, never hang it by gravity, and make sure the client is on EKG monitoring if they are at risk for dysrhythmias. Quick review: potassium is one of the most dangerous IV medications. The NCLEX loves testing this. Here are the safety numbers to remember. Never give potassium as IV push. Dilute it in fluid, usually 10 to 20 milliequivalents in 100 milliliters. Infuse at 10 milliequivalents per hour or less in a peripheral line, and up to 20 milliequivalents per hour in a central line with monitoring. Always check urine output and renal function before starting. If the kidneys can't excrete, the client can slip into dangerous hyperkalemia. These safety limits are must-know values for your exam. Now let's do a drop-down fill-in on hyponatremia, cause and a key GI finding. A 70-year-old client with heart failure has been taking loop diuretics for several weeks. Today, the sodium is 128 milliequivalents per liter. Normal is 135 to 145. Complete each statement by choosing from the drop-down. Hyponatremia is most often caused by excessive options: sodium loss, sodium intake, or sodium retention. Expected gastrointestinal manifestation equals options: hypoactive bowel sounds, hyperactive bowel sounds, or absent bowel sounds. Make your selections. The correct answers are sodium loss and hyperactive bowel sounds. Rationale: loop diuretics promote sodium excretion in the urine, leading to sodium loss and dilutional hyponatremia in heart failure. Hyponatremia often increases gastrointestinal motility. You'll hear hyperactive bowel sounds, with cramping or diarrhea. Why not the others? Sodium retention or excess sodium intake point toward hypernatremia. Hypoactive or absent bowel sounds are more consistent with ileus, hypokalemia, or hypercalcemia, not typical for hyponatremia. NCLEX alert: limit correction of serum sodium to no more than 8 to 12 milliequivalents per liter over 24 hours. Rapid correction risks osmotic demyelination. Always assess for neurologic changes such as confusion or seizures. Quick review: classify hyponatremia by volume status: hypovolemic from losses, euvolemic as in SIADH, and hypervolemic in heart failure and cirrhosis. Treatment follows the type: gentle isotonic fluids for true volume loss, fluid restriction for dilutional states, and hypertonic saline only for severe symptomatic cases with close monitoring. Great! Let's keep going with the advanced NGN set. Let's start with an assessment-based drag-and-drop Cloze question on fluid volume deficit. A 65-year-old client has had vomiting and diarrhea for 3 days. The nurse suspects fluid volume deficit. Complete the assessment chart by dragging the correct value or status into each blank. Findings: blood pressure, blank. Central venous pressure, blank. Skin turgor, blank. Urine specific gravity, blank. Answer bank: low, high, poor, decreased. Pause and fill the chart. The correct chart is blood pressure, low. Central venous pressure, decreased. Skin turgor, poor. Urine specific gravity, high. Rationale: low blood pressure and decreased CVP reflect reduced circulating volume. Poor skin turgor signals dehydration. A high urine specific gravity means the urine is concentrated because of fluid loss. NCLEX alert. In elderly clients, confusion can appear before hypotension. Always replace fluids carefully in cardiac patients to avoid overload. Now let's switch from assessment to intervention. A drag-and-drop Cloze on IV fluid therapy and potassium safety. A client is admitted with dehydration and serum sodium of 148 milliequivalents per liter. Fill in the blanks with the correct choices. The nurse expects an order for blank to lower sodium gradually. For severe hypovolemia, the nurse would instead give blank first. Potassium chloride may be added, but only if blank is adequate. Answer bank: 0.45%. Normal saline, 0.9%. Normal saline. Urine output. Pause and make your selections. The correct fills are 0.45% normal saline, a hypotonic fluid for gradual sodium correction. 0.9% normal saline, isotonic, used when blood volume is critically low. Adequate urine output. Potassium should never be given without confirming kidney function. Rationale: hypotonic fluids correct hypernatremia slowly. Isotonic fluids restore circulation in hypovolemia. Potassium requires functioning kidneys to avoid dangerous accumulation. NCLEX alert. Never use hypotonic fluids in clients with increased intracranial pressure. Always check urine output before giving potassium. No urine, no potassium. Here's a bow tie style question on fluid overload. This pulls together assessment, intervention, and monitoring. A client receiving continuous IV fluids develops crackles in the lungs, shortness of breath, and increased blood pressure. Complete the bow tie by selecting 3 nursing actions to take immediately, and 3 parameters to monitor closely. Options: possible nursing actions: slow or stop infusion, elevate head of bed, administer oxygen, increase infusion rate, give IV push potassium. Parameters to monitor: lung sounds, oxygen saturation, blood pressure, urine-specific gravity, pedal pulses. Pause here and make your selections. The correct actions are slow or stop the infusion, elevate the head of the bed, and administer oxygen as prescribed. The correct parameters to monitor are lung sounds, oxygen saturation, and blood pressure. Rationale: fluid overload requires first stopping the source, then improving oxygenation, and monitoring for worsening pulmonary edema. Pedal pulses and urine-specific gravity are important in fluid balance overall, but they do not directly address acute overload. NCLEX alert. Always assess respiratory status first in suspected fluid overload. Airway and breathing take priority. Now we're moving into acid-base balance and arterial blood gases, a high-yield area for the NCLEX. These questions test your ability to interpret pH, carbon dioxide, and bicarbonate values, link them to the right condition, and decide what the nurse should do. Let's start with a bow tie question that combines ABG interpretation with anxiety-induced hyperventilation. A 24-year-old with acute anxiety has arterial blood gases drawn. pH 7.45, carbon dioxide 30 millimeters of mercury, bicarbonate 20 milliequivalents per liter. Complete the bow tie by selecting 2 contributing factors, the most likely condition, and 2 appropriate nursing actions. Options. Contributing factors. Pick 2. Acute pain, panic with hyperventilation, prolonged diarrhea, high altitude exposure. Most likely condition. Pick 1. Metabolic acidosis compensated, respiratory alkalosis compensated, respiratory acidosis uncompensated. Actions. Pick 2. Coach paced breathing or rebreathing, address anxiety with calm environment, give IV sodium bicarbonate, restrict fluids. Pause here and make your selections. The correct answers are contributing factors, panic with hyperventilation and high altitude exposure. Most likely condition, respiratory alkalosis compensated. Actions. Coach paced breathing or rebreathing and address anxiety with calm environment. Rationale. A low carbon dioxide with high normal pH and low bicarbonate shows respiratory alkalosis with renal compensation. Hyperventilation from panic or hypoxia at altitude lowers carbon dioxide. IV bicarbonate treats metabolic acidosis, not indicated here. Fluid restriction has no role. NCLEX alert. In respiratory imbalances, pH and carbon dioxide move in opposite directions. Compensation is suggested when pH returns toward normal, while CO2 or bicarbonate remain abnormal. Here's a select all that apply question on metabolic alkalosis caused by nasogastric suction. A client on continuous nasogastric suction has new lab results suggesting metabolic alkalosis. Which findings are consistent with this disorder? Select all that apply. Options. History of persistent vomiting, loss of gastric hydrochloric acid, hyperventilation compensation, meaning decreased respiratory rate and depth, elevated bicarbonate, low carbon dioxide from a primary respiratory process, tetany or paresthesias. Pause and make your selections. The correct findings are history of persistent vomiting, loss of gastric hydrochloric acid, elevated bicarbonate, tetany or paresthesias. Rationale. Vomiting or NG suction removes hydrochloric acid, leaving the body alkalotic. This raises pH and bicarbonate levels. Alkalosis increases neuromuscular excitability, causing symptoms like tetany or paresthesias. Why not the others? Compensation in metabolic alkalosis is hypoventilation, not hyperventilation. A low carbon dioxide from a primary process describes respiratory alkalosis, not metabolic. NCLEX alert. In metabolic alkalosis, expect increased pH and increased bicarbonate, with compensatory hypoventilation to retain carbon dioxide. Now MCQ, uncompensated respiratory acidosis. Which arterial blood gas, set best, represents uncompensated respiratory acidosis? Option A, pH 7.52, carbon dioxide 28, bicarbonate 23. Option B, pH 7.12, carbon dioxide 90, bicarbonate 22. Option C, pH 7.50, carbon dioxide 30, bicarbonate 30. Option D, pH 7.36, carbon dioxide 50, bicarbonate 29. Pause and make your choice. The correct answer is option B, Rationale. A pH below 7.35 shows acidemia. The carbon dioxide is elevated at 90, confirming a respiratory acidosis. The bicarbonate remains normal at 22, which means the kidneys have not compensated yet. Why not the others? Option A shows alkalemia with low carbon dioxide. That's respiratory alkalosis. Option C shows an alkalotic pH with elevated bicarbonate, metabolic compensation toward alkalemia. Option D shows a near-normal pH with both carbon dioxide and bicarbonate elevated. That's compensated respiratory acidosis. NCLEX alert. In uncompensated states, the pH is abnormal and the opposite system, kidney or lung, has not shifted bicarbonate or carbon dioxide to balance it. Next, let's look at how vomiting affects acid-base balance. Prolonged vomiting removes gastric hydrochloric acid, which shifts the body toward alkalosis. Here's a drop-down question. Can you predict the expected arterial blood gas values? A client with a 3-day history of nausea and vomiting presents with tachycardia and shallow breathing. Select the expected arterial blood gas pattern. pH, up, normal, or down. Carbon dioxide, up, normal, or down, representing compensation. Bicarbonate, up, normal, or down. Pause and make your choices. The correct answers are pH is up, indicating alkalemia. Carbon dioxide is up, showing compensatory hypoventilation. Bicarbonate is up, the primary cause, metabolic alkalosis. Rationale. Vomiting removes gastric hydrochloric acid, leading to metabolic alkalosis. This raises both pH and bicarbonate. To compensate, the lungs retain carbon dioxide, increasing PaCO2. NCLEX alert. Remember, in compensation, the opposite system shifts in the direction that brings pH back toward normal, but never overcorrects. Now, let's practice a highlight the text question. Respiratory alkalosis is often caused by overventilation, like in an anxiety attack or ventilator settings set too high. Your task is to highlight the symptoms that best match this condition. Highlight the 3 symptoms most consistent with respiratory alkalosis. The client reports lightheadedness, bradypnea, nausea, confusion, hyperkalemia, tingling of fingers. Select the best 3. The correct highlights are lightheadedness, nausea, confusion, tingling of fingers. Why not? Bradypnea is the opposite of what you expect. Respiratory alkalosis is driven by hyperventilation. Hyperkalemia is linked to acidosis, not alkalosis. Rationale. Overventilation lowers carbon dioxide, causing alkalosis. Classic signs are neurological excitability, lightheadedness, paresthesias, nausea, and confusion. Tachycardia is also common. NCLEX alert. Always think anxiety attack or overventilation on a ventilator. Both can cause respiratory alkalosis and neurosymptoms. Let's try a matrix or grid question. Here, you'll classify different clinical situations by their primary acid-base disorder. The key is to think about the mechanism. Is acid being lost? Is carbon dioxide trapped? Or is the client blowing off too much CO2? Classify each condition by the most likely primary acid-base disorder. Options: metabolic alkalosis, respiratory alkalosis, respiratory acidosis, or metabolic acidosis. Conditions: NG suction or persistent vomiting, anxiety-induced hyperventilation, atelectasis with hypoventilation, multiple rib fractures causing shallow breathing, Diabetic ketoacidosis with Kussmaul respirations. Pause and make your classifications. The correct classifications are NG suction or vomiting, metabolic alkalosis from loss of hydrochloric acid, anxiety with hyperventilation, respiratory alkalosis from low carbon dioxide, atelectasis, respiratory acidosis due to hypoventilation and CO2 retention, rib fractures, respiratory acidosis, shallow painful breathing limits ventilation, diabetic ketoacidosis, metabolic acidosis with Kussmaul respirations as compensation. Rationale: always tie the ABG imbalance back to the mechanism. Loss of acid equals alkalosis. Hypoventilation traps carbon dioxide, leading to respiratory acidosis. Hyperventilation blows off carbon dioxide, causing respiratory alkalosis. Excess fixed acids like ketones drive metabolic acidosis. NCLEX alert. Remember, Kussmaul's respirations are the hallmark compensation for DKA, deep, rapid breathing to blow off carbon dioxide.
And that wraps up our practice with acid-base balance and arterial blood gases. You've now seen how to interpret numbers, link them to conditions, and choose the right interventions. Now let's cover another NCLEX favorite, blood transfusion safety. This is high yield because it combines IV skills, patient safety, and rapid recognition of adverse reactions. A nurse is preparing to administer packed red blood cells to a client with symptomatic anemia. The unit has just arrived from the blood bank. Which action is the priority before starting the transfusion? Option A. Start the infusion at 125 milliliters per hour to prevent fluid overload. Option B. Verify the client's identification with another licensed nurse. Option C. Warm the blood to room temperature before starting the infusion. Option D. Flush the IV line with 5% dextrose before beginning transfusion. Pause and select your answer. Rationale: two licensed nurses must independently verify the client's ID, the blood product type, and ABO compatibility. This is the single most important safety step to prevent a fatal transfusion error. Why not the others? Option A. Infusion should always begin slowly, about 2 milliliters per minute for the first 15 minutes, to monitor for reactions, not a fixed higher rate. Option C. Blood products are stored cold but should not be warmed unless using a blood warmer for rapid or massive transfusions. Room temperature warming increases bacterial risk. Option D. The line should be flushed and primed only with normal saline. Dextrose causes hemolysis of red cells. Always verify client ID and blood product details with another nurse before initiating transfusion. The first 15 minutes of the infusion carry the highest risk for a reaction. Monitor closely during this window. Next question on transfusion reaction emergency. 10 minutes after initiating a blood transfusion, the client reports chills, fever, and flank pain. The nurse notes hypotension and tachycardia. Which action should the nurse take first? Option A. Slow the transfusion rate and notify the provider. Option B. Stop the transfusion and maintain IV access with normal saline. Option C. Administer acetaminophen and continue monitoring. Option D. Send the blood bag and tubing to the laboratory later. Pause and make your choice. The correct answer is option B. Stop the transfusion and maintain IV access with normal saline. Rationale: a febrile or hemolytic transfusion reaction is suspected.
The immediate priority is to stop the transfusion and keep the vein open with normal saline using new tubing. This preserves access while preventing further exposure to the incompatible blood. Why not the others? Option A. Slowing the rate does not prevent worsening of the reaction and delays emergency care. Option C. Giving acetaminophen treats fever only but does nothing for the immune reaction. Option D. Sending the blood and tubing to the lab is important, but only after client safety is secured. NCLEX alert. At the first sign of a transfusion reaction, stop the transfusion immediately, maintain IV access with normal saline, and notify the provider. Save the blood bag and tubing for laboratory investigation. That concludes our review of transfusion safety and emergency management. Remember, the priority steps are always verify before you start and stop immediately at the first sign of a reaction. These questions show how NCLEX loves to test patient safety in high-risk procedures. Now let's shift gears to laboratory reference questions. These questions test your ability to spot the most urgent value among multiple abnormal labs. Let's begin with renal function. A client with suspected renal failure has the following labs: serum creatinine 3.1 mg per deciliter, blood urea nitrogen 48 mg per deciliter, serum potassium 6.0 milliequivalents per liter. Which finding requires the most immediate intervention? Option A, elevated BUN. Option B, elevated creatinine. Option C, hyperkalemia. Option D, elevated creatinine and BUN together. Pause and choose your answer. The correct answer is option C, hyperkalemia. Rationale: elevated BUN and creatinine confirm renal dysfunction but are expected in renal failure. Hyperkalemia at 6 is life-threatening because it can trigger cardiac dysrhythmias. This makes it the priority finding. NCLEX tip: always apply the ABCS plus safety. Potassium derangements, especially hyperkalemia, create an immediate risk to circulation and must be addressed first. Next, let's test sodium imbalance, especially severe hyponatremia, which is a critical NCLEX concept. Always connect neurological changes, like confusion, with sodium levels. A client presents with confusion, nausea, and a serum sodium of 118 milliequivalents per liter. The normal range is 135 to 145. Which intervention should the nurse anticipate? Option A, administer hypotonic 1V fluids. Option B, prepare to administer hypertonic saline. Option C, encourage increased oral water intake. Option D, restrict dietary sodium. Pause and select your answer. The correct answer is option B, prepare to administer hypertonic saline. Rationale: severe hyponatremia, defined as less than 120, can cause seizures, coma, and even death. Hypertonic saline, 3% sodium chloride, is used cautiously in acute severe cases. Why not the others? Hypotonic fluids and extra water intake would worsen hyponatremia. Sodium restriction is for hypernatremia, not hypo. NCLEX tip: always connect neurological changes with sodium imbalance. In hyponatremia, confusion and seizures are red flags requiring immediate intervention. Now let's look at a hematology lab value, hemoglobin. This is a critical number to know because it directly reflects oxygen carrying capacity. A 48-year-old client undergoing chemotherapy has a hemoglobin of 6.8 grams per deciliter. The normal range is 12 to 16. Which order should the nurse anticipate? Option A, begin epoetin alpha therapy. Option B, transfuse packed red blood cells. Option C, encourage a high-protein diet. Option D, administer iron supplements orally. Pause and choose your answer. Rationale: A hemoglobin below 7 is critical and requires immediate transfusion. This is the fastest way to restore oxygen delivery. Why not the others? Epoetin alpha stimulates red blood cell production but takes weeks to be effective. A high-protein diet and iron supplementation may help long-term, but they do not address an immediate crisis. NCLEX tip: always prioritize interventions that correct oxygen delivery quickly. In anemia this severe, transfusion is life-saving. Finally, let's cover white blood cell counts, one of the most important lab values to recognize during chemotherapy. Severe neutropenia places the client at extremely high risk for infection. A client receiving chemotherapy has a white blood cell count of 2,000 per cubic millimeter. The normal range is 4,500 to 11,000. What is the priority nursing action? Option A: place the client in protective isolation. Option B: monitor daily weight. Option C: encourage a high-protein diet. Option D: monitor for bruising. Pause and select your answer. The correct answer is option A: place the client in protective isolation. Rationale: a white blood cell count below 2,000 is severe neutropenia and signals extreme risk of infection. Protective isolation and strict hand hygiene are the priority interventions to keep the client safe. Why not the others? Monitoring weight or diet are supportive, but not urgent. Bruising is more closely related to low platelet counts, not white blood cells. NCLEX tip: remember, when WBCs are dangerously low, the nurse's first job is to protect from infection. Excellent work making it through this entire session. We've tackled some of the highest yield areas for the NCLEX: intravenous therapy, electrolytes, acid-base balance, blood transfusion safety, and laboratory values. You didn't just practice questions. You built the kind of clinical judgment that the exam is really testing, spotting the danger, prioritizing the patient, and choosing the safest intervention. Remember these golden rules. Stop a transfusion at the very first sign of a reaction. Never give potassium through an IV push. Always connect sodium changes to neurological status. And use ABC priorities when interpreting labs or blood gases. Keep practicing, keep reviewing rationales, and you'll keep getting stronger. This is how you build the confidence to walk into the exam and pass the NCLEX. I'll see you in the next lesson.